This episode of The Dental Guys is brought to you by the Dental Crafters Network, your implant restorative connection. From surgical planning to patient-specific guides, quality implants, and final restorations, the Dental Crafters Network provides one relationship with infinite possibilities. Call 1-800-472-8302 today. That's 1-800-472-8302.
You're listening to The Dental Guys, episode 53, Practice Changers 2017, Occlusion, TMD, and Sleep Medicine. 2 years of clinical podcasting in the books. We make some sense of what these complex subjects have done in our practice and how a simple fix can lead to saving a patient's life. We discuss how we can simplify your life with this week's product of the week. So get ready to score your tonsils this week on The Dental Guys.
Welcome to this week's episode of The Dental Guys. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy.
And man, Wes, this is a big one. Not only is this the kickoff to season 3, but we are currently recording live. Facebook Live.
Stream, man. If you got an opportunity to tune into this, that was a special thing.
Yeah, we didn't give you much notice, so if you didn't tune in, it doesn't mean we didn't love you. We just really kind of just decided to do this last minute. Wes is like, I'm doing this.
Season 3's here, man. We got to come in a big way. So season 3, and super duper pumped about that. So for all you watching and listening on Facebook Live, hey, maybe we'll do this more in the future. We're excited about what we can do with technology, and John and I are junkies when it comes to this, and it's just going to get better from here on out, John. But what's going on with the Dental Guys?
Oh, wow. Well, you know, season 2 has been a year of growth for us. It's kind of hard to believe that we're getting into our 3rd year of doing this podcast. I mean, it's pretty awesome to think about it. But, you know, you think about what is coming up, and I think that some of the things that are coming up, we can't reveal, but we can at least give you some ideas. You know, one of the things we can tell you is that we will be having more guests that are some people that you know from Spear Education. We can tell you that. We can tell you be having some other guests that will be very special that I think everybody will recognize. We can tell you that we're going to be looking at some interesting things coming up around the time of Voices of Dentistry. So stay tuned for that time because, of course, Voices of Dentistry is coming up. For those of you who don't know, Voices of Dentistry is a gathering of dental podcasters. Some of the best dental podcasters out there will be gathered together in Scottsdale, Arizona. And it's January 26th and 27th, 2018, downtown Scottsdale. You can go to voicesofdentistry.com to check that out and register. We would recommend you register soon because spaces are limited. Last year, we really had a great turnout. This year should be even bigger because it grows upon itself. And I think that we're going to be bringing it to Voices of Dentistry, as I think everybody is. Yeah. And there's going to be some interesting things that are going to maybe happen at Voices of Dentistry this year for us.
Well, John, we're going to be on stage too, and we're not going to record a podcast on stage. We'll be recording off stage in a podcast lounge, but we're going to be recording those shows separately, but we're actually going to get an opportunity for John and I to lecture together, which, to be honest with you, we've never really done in a formal way, and so I'm super pumped about that. And we're going to be bringing a great topic. I know you guys are going to just love it. And something else that I want to bring up is that we want to give a shout out to the people that have helped change our practice, and that's Spear Education. But Spear Education has asked John and I to be online Spear Digest contributors. And man, John, I'm super humbled about that.
Yeah, that's a big deal. That's a big deal. They want, you know, they have kind of seen that we're interested in doing clinical podcasting and that we're, you know, committed to trying to push our limits as dentists and get better. I think our audiences are similar. And so they kind of look at us as somebody that can contribute more to what they're trying to do, and we look at them the same way.
Yep.
So that's
take it to the next level, man. That's what they're about. It's what we're about. And tough questions and good answers.
Exactly. And we've really had fun getting to interview some of the folks from there, as well as a lot of our other guests too, where we don't kind of take it easy on them. And I think that's what, season 3, we look at this being bigger and better than ever. We know we're going to have some big things going on. And I think, again, a lot of that you're going to see really starting to get kicked off right about the beginning of the new year, as we start seeing what happens around that time of Voices of Dentistry. And, even coming up soon, we've got some interesting information for you guys coming up on this show about what has really changed in our practice. What's changed our practice over the last
practice changers,
year
baby.
We've been doing this show.
Yeah.
And so, for those of you who are listening on Facebook Live, you got a little preview to that. So we're just going to make you kind of, interested. And we'll now kind of get into that part of the show where we have to kind of say goodbye to the Facebook Live people. So we're sorry to say goodbye.
This is not the end, Facebook Live. This is the beginning. So we're excited about this. So for all you tuning in, we'll see you on the next one. Practice Changers last year was all about what really made us think about what we were doing and actually make a shift and turn our practices in a different direction. And I think really where it all started was with Spear Education. We decided we were going to dive into the big word occlusion.
Yep.
And so John and I went and took the TMD and occlusion course, and wow. I mean, demystifying occlusion is the term that they use at Spear Education, and it definitely changed for me in my practice how predictable I've become in not only TMD treatment, but also capturing bite registration records for full arch cases, for denture cases, and for just being more predictable about putting the joint in the most repeatable position.
Yep.
And John, as I kind of went through, trying to think that I knew what I was doing, I began to get more consistent and repeating from day to day what I had been taught at Spear. And really, so what are we saying here is that for the first part of this journey for Practice Changers started with TMD, temporal mandibular disorder, and learning how to predictably treat one of the hardest things that we see in our practices. You can either choose to ignore it or you can choose to treat it. And John, that's what I was really doing, is I was ignoring the grand scope of it and really just kind of treating TMD with a blanket catch-all type of approach, which it works to some extent, but then there's some that you just get frustrated about, and you think you want to try to help people, and then you end up having to refer these out. And for me, it was a frustrating thing. And so, John, talk a little bit about your frustrations.
Yeah, I had very similar to a lot of dentists. We're really not taught anything about this in dental school and in most residencies, I think, because frankly, we don't really have the ability to even have like a frame of reference. We've not done, you don't have time or the ability to do full arch dentistry, really, other than dentures when you're in school, so that you don't really have any idea of what to do.
Right.
And then you also don't really see patients long enough to see a lot of occlusal consequences of things. When you restore somebody with, say, a crown on number 15, you might encounter the need to adjust occlusion. Right. But chances are you're not going to have a lot of opportunities where you're actually going to know, hey, something I did made a difference. You're especially not going to know whether something, doesn't work. I don't think. I think you're just sort of going.
We talked a little bit about that.
Yeah,
So
yeah. Well, go ahead, Wes. Go ahead.
No, we talked a little bit about that last week
Yeah.
on the week before last on our bonding episode, is how sometimes you really don't see the end result of what you may have misdiagnosed or not diagnosed for 5 to 10 years, and then veneers start coming off.
Right, and I think that when it comes to my frustrations, it was, that I never really had a system. I was doing things as best I knew how, or how I would like hear at some lecture from somebody, but there's really not a great concise amount of like research on these topics. There's a lot of controversy about things, or at least I kind of thought there was until I sort of started reading through it with some guidance,
Yeah.
But for me, it was like you say, it was patients who, sometimes got better, and I was like, that's great. And then I'd run into something where I'd do it the exact same way, and it wouldn't get better, and I didn't understand what was going wrong, or really even how to move on from there, and you'd end up having to just, refer them somewhere else and kind of hope for the best. And so what ended up happening is, I actually took the Spears seminar years ago on occlusion. That was just a short, like, half-day lecture at the Hinman meeting. I saw Frank Spear talk about this. Was years ago. And I kind of started going, okay, so this is a system. And I guess both of us realized that we actually needed a system, because it doesn't mean that Spears' way of doing things is better. It's not about that at all. It's just, it's proven by evidence, and it's a systematized approach. And we both realized we needed that. And you really, I don't think, can get that from a seminar. You really have to get that from hands-on with somebody who's there, showing you what to do. And that was what changed. It started the change for me, because when I saw, first of all, when I understood the research, because for me, I got to know where it comes from, all of a sudden, I started going, okay, now I see where I need to start. And then we needed a system that we could plug patients into and have the same type of options, available to us each time. And I think once we went out there, I mean, for me, I got back from that, and it was like everything just kind of made sense to me with patients that I'd been struggling with. I started seeing things. It was interesting. My assistant, one of my assistants that I did some veneers for, she went through ortho, and she was having headache problems.
Oh no!
And we'd had her in a splint. And why? Because that's just what I did for people. When I didn't know what was going on, just make them a splint.
It's that blanketed approach that we've all taken, and everybody's there at one point in time.
Yeah, and she didn't really get better, and I was like feeling very inadequate as the dentist, because I'm like, I can't even fix my dental assistant. Yeah, and so I get back, and I understand, and I put her in a leaf gauge, and I started trying to figure out what was going on, and realized that she had a very, very clear problem going on with a prematurity between her second molars, very clear, and did just a very slight amount of equilibration based upon what we learned. And she's, honest to goodness, I mean, if she's listening to this right now, she's not had a headache. I mean, it's weird, man. It's not weird because it works, but it's like, she's not had a headache. I just talked to her today. I was like, how's your headache? How have your headaches been? Haven't had a headache since the day we adjusted that. Haven't had that tightness.
Man, that's got to make you
muscles.
Feel really good.
Yeah, and all of a sudden you feel like I can treat my dental assistant now, whereas before I felt, and all of a sudden then your team, you start to explain this to them, and at first they're like, what are you talking about?
How many appliances did you just start going through, and you're the team's like, I don't know about this. He's making many.
Yeah, you're trying to explain like CR versus CO, and you're trying to talk about guidance, and you're trying to talk about, and it's not like I've never talked about that stuff before,
right?
But not really intentionally. I didn't really do intentional teaching with my team, and so now I'm doing that, and they're like, whatever, and they're trying. But it didn't really make a lot of sense. And then we start seeing these patients coming in.
Oh, yeah.
And I'm like, I'm seeing them, and I'm going, okay, when we prep the second molar, I want you to watch how much I reduce. And then I want you to watch, this cracked tooth. I want you to watch after I reduce and how it closes down more. Now, all of a sudden, when you make your temporary, and you see your temporary is now showing through, you know why.
Right.
You know why. And so all of a sudden, they start seeing things. And that's when it really got exciting for me, is when my team actually starts seeing things and they start coming back to me and they're like, I think this patient is hitting prematurely on her second molar and she's got an open contact there now. And I'm like, that was the moment where I knew that all of this work and training actually was making a difference in my practice, where I started seeing my team going, you know, I think I know what this patient's, because I've seen you treat it successfully, and all of a sudden they want our patients to know that I know how to handle this now.
Yep. I think that's the thing. That's the wow moment, and that's the practice changer. Like when we say practice changer, what we're saying is that our practices will never be the same ever again. And you, when you want to bring something in like this and turn a ship, and it's very difficult to come back from a CE course, and where we fail as dentists is we fail to take our team and bring them along, because you come back excited and they're not believers because you've been working all weekend at one of these courses. You're the believer.
Right.
And now you have to bestow upon them your beliefs, and they have to believe you. And so it takes a long time to sometimes get that across. And really for me, what it was, I think, is you have so many of these cases going on, like you said, and you immediately know the answer. When you get back, you call that patient. I don't know how many times we did that. It's like, hey, you know that patient we've been having trouble with? Let's go and get them back right now. Let me show you why.
Call them back in because I actually know what to do now.
I actually know what to do now. You know, it's like, yes. And we fix them, and then the assistant's like, okay, all right, I see what you're talking about. And I'm like, okay, so how about your headaches that we've been battling with for 4 or 5 years?
Exactly.
Let's go ahead and let's do a thorough exam. And I've been working on for the past probably 9 to 12 months, refining my comprehensive exam, my new patient orientation. I think you call it your new patient what do you call it? Experience. We call ours an orientation. John calls his an experience. And we have now refined our exam down to where it is a giant list of things that we're going through. And it's, clickable PDF. It's really turned into something that allows us to go back and repeat certain things that help us to document what's going on with these patients and paint the story. And some of you think, well, all I'm doing is like, cutting crowns and fixing broken teeth. And I think that's great. But whenever you have these cases where people come in and they're having headaches and they're breaking teeth and you don't know why, that's whenever you start really like, oh my goodness, what is really going on here? And like I said, I think I had a blanketed approach to treating TMD. Now, like John said, whenever he went to the seminar, they had pretty much said we've systematized, meaning we have taken and made a decision tree on how to treat patients, and it's like a yes-then statement, like from an algorithm or something. And it's like, if this happens, do this. If this happens, do this. And you just keep going down that tree, and it really.
Well, what about this, Wes? What about splint design? I mean, how many people, if you were to ask, I mean, just think about this yourself, dentists who are listening to this right now. I want you to ask yourself right now, why do you use the splint you use? Why do you use the occlusal guard that you use? And if we're honest, probably, I don't know, 99 out of 100 of us, or maybe, 90 out of 100 of us, we don't really know.
Right.
Don't really have any idea. And when can you
somebody told me to do it.
Yeah, when can you use an NTI?
Right.
When should you not? When should you use a full arch appliance that's flat?
Right.
When should you use one that has a ramp? When should you make a lower appliance? What about it? When should you transition somebody from one to the other?
Yeah.
What if one doesn't work? Is another one going to work?
Yeah.
How do you handle somebody that's popping their, and clicking versus somebody who's just got muscle pain? How do you even figure out if it's a joint or muscle problem before you even start giving a patient any type of appliance? And these are the kind of questions that, it's really kind of sad. Like, I'm ashamed
I am too.
of the fact that I could not answer any of those questions with real confidence.
With confidence, right.
I could
Remember
say
me
some
telling you,
things
like,
about ideal occlusion and CR, and I tried my best to kind of say things that I thought would make sense. But dude, in the end, a lot of it was just BSing.
Well,
I was like,
I think
don't
that
really
we
know.
all
I didn't really know.
have little things that we do that we are pretty much along the lines of you're trying to do the best that you can with what knowledge you have.
Yep.
But it's really such a large subject, the TMD and occlusion, that until you take one of these courses, you really can't put it all together. And then when you do, it's an aha moment. And then it's like, oh, okay, now, like, I actually have a game plan going into this.
That's right.
Now,
and you know why, instead of just what to, and because what you're doing right now, if you're listening and you're treating everybody kind of the same, what you're doing is just doing empirical treatment based upon your experience. And so if your experience is splints
that's
work,
what I was doing,
then you're doing splints. If your experience is splints don't work, you're not doing splints. I had somebody one time in my office who came in to help me for a little while during kind of crazy time. Just tell patients, hey, if your jaw's hurting, go buy a splint from Walmart.
Oh, my word.
And that was what he told everyone in his practice for 35 years, because he didn't believe that splints worked, or he had had bad experiences. And so if that's how you're making decisions on what appliance to use, or how you make decisions on your treatment, you owe it to yourself and your patients. Even if you don't do, the cool thing is it's not just you owe it to them to be a doctor, because that's what we're supposed to be, is somebody who actually knows what we're doing. And that's sad that we sometimes, that I didn't always know with these patients. Like, why did I not go find that out? I finally did, but it took me how long?
Right.
But the cool thing is that it actually works.
Yeah, it does.
So it's not just that you're going to find out so that you can know. You're going to find out, and then you can come back and you can actually fix people. And this kind of stuff, I'm not saying it's easy, because some of these patients that have really severe TMJ problems, I don't want to deal with them. Yeah. Because some of them have got a lot more going on than just TMJ. But I'm talking more about just the people that you want to fix because you're doing restorative treatment,
right,
or you're doing ortho restorative treatment, and you need to understand where to restore them, how to restore them, how not to mess them up. If you don't know how to do that, go figure it out, because it works and it's repeatable and it's so much more predictable than where I was living just a year ago. But the interesting thing, I think we came back, both of us, and we're calling each other, we're texting each other, we're like, can you believe all the patients that we're doing this treatment with now? And people are getting treatment, and they're getting better, and we're figuring stuff out. So it was a real practice changer, and I know sometimes you listen to this show, and I know we're talking a lot about Spear, and you maybe think we're like getting paid. It's not about Spear, although we think they do a good job. But we just found that, Wes, like we say it all the time, was that $5,000 worth $5,000?
Well, I think I told you that week that I came back from that occlusion course that I doubled. I doubled the revenue off the course immediately. Yep. And it was just a simple diagnosis of like, boom, there's the problem, fix it, and fixed it. And now we're not breaking teeth anymore. And because of that, you're able to fix and diagnose and treat patients. I like practicing empirical dentistry, but it's not the best way to practice, because of course you're going to agree with yourself, Yep. And
Yep, that's right. And you can be biased so easily by just your experiences.
you
I mean,
can,
if things aren't
man.
going well,
You can get in a rut, and it's
if
like
people aren't getting better, you're like, well, I guess that just doesn't work.
it just doesn't work, and that's not really great dentistry. It's not a great practice, and I want to challenge.
Now, coming out of that,
Yeah.
really that goes right into the product of the week for this week.
Well, let me just tell you right now, man.
Yeah, because one of the things that you learn out of this course we took is you learn several ways to get to a stable, repeatable centric relation position, and they challenge you to do it 3 different ways.
Right.
And mount the same casts using 3 different bite records, and then to compare and see which ones were accurate, how accurate they were, comparing them to each other, how precise, I guess, the measurements
Well, really,
were.
the precision is what you're looking for.
Yeah, precision.
Repeatability.
Yeah, and so then that's right, because the accuracy, is not the thing, it's the precision. So we got a chance to use some different techniques and products, and one of those was the product of the week, which is the leaf gauge.
Oh, man.
And the leaf gauge really was a huge practice changer in and of itself for me.
Right.
Because if you would have asked me what a leaf gauge was,
Well, I knew what it was, but I didn't use it right.
I would have been like, well, it helps you to get to centric relation, because I'd seen somebody talk about it on some, but I didn't understand how to use it.
Yeah, and you didn't know protocols for like how long do you leave it in somebody's mouth and let them sit there to let actually relax, and can you achieve in somebody that has local muscle soreness because of whatever diagnosis that you might come up with. Let's save part of that for the rest of the show here, because we're getting ready to break into something here just in a second. But think about this: how long do you leave somebody in leaf gauge? And if they're so tight, how can you accurately capture a bite, or do they need to be in an anterior discluding device, or some people will say an anterior deprogrammer for a while, for a week or so, to get their muscles relaxed? And what if when you put them in the leaf gauge, the joints actually hurt? What is that telling you? And so all of these things you figure out.
And you just need a tool in your practice.
And this tool right here, the leaf gauge, will change your adjustments on your night guards alone dramatically. Okay, so let's talk about the leaf gauge and what it does for us. Let's use the most standard appliance, John. Let's say that the patient has gotten better in a temporary appliance or an interim appliance, and you're coming in and you're going to make them a definitive, let's just make it the most simplest one, John, just for sake of argument, a flat plane, centric stops all across, and cuspid rise and protrusive ramps. Okay? I think everybody understands that. That means when the patient goes into protrusives, the canines rise up, lifting the posterior, discluding the posterior, and and we also get some helpers. We got some helper teeth like 20, 24, and 25 maybe help us out in that protrusive moment so that there's no tremoring of the muscles, the lateral pterygoids. And so then if we go left lateral, we don't have any draggers or what we call ipsilateral or balancing contacts. We have that canine rise to if we go working movement right. And we go working movement left, we have canine rise. And we don't have any dragging teeth or balancing contacts. So what this tells us is this patient is in centric relation and they have cuspid or canine rise. They're in the most perfect balanced occlusion. How do you get a patient the day that you do your TrueDef scan, John? Now, you do your TrueDef scan, you do an upper and lower scan, and you capture a habitual bite with the scan. But nowadays, what you do is you put them in a leaf gauge for 15 minutes and you have them go into protrusive and relax their jaw. You have them go into protrusive and then relax their jaw. Or you have them wear in the morning their deprogrammer. And they show up and you're the first person to see their back teeth touch in centric relation. And you capture that with either hard registration wax or a rigid bite registration material. Okay? You send the habitual bite in the TrueDef scan to your dental lab. Then you write in the notes section, please mount in CR with the meld hard registered bite. Okay? Now, one would say, well, why can't you capture the CR with the TrueDepth scan? Well, you can. In fact, you can.
Yep.
But the concern is that when they print that model, they only print it in 50 micron layers, unless you want to print it at a higher degree of accuracy, and 50 microns could be enough to throw off your bite registration.
For sure.
And so I've been sending along my bites. I don't know what you've been doing, using the leaf gauge in that way. So when you get it back, here's the kicker, John. Here's what the leaf gauge does to you. Your assistant comes in and says, hey, I went ahead and put the guard in, and then I put the leaf gauge in for 15 minutes, and I put the guard in, and I've leafed them down, and there's only like polishing adjustments.
Yeah.
It's like you've treated this patient so well that the predictability and the precision goes up. I mean, are you seeing the same thing, John, with this this particular modality?
It's the ability to, and I that kind of treatment is an excellent use for it. I'm using it a lot for the situation where the patient comes in with pain, and you can go through diagnosis, right? And
this is an aha moment for the assistants too, isn't it?
Yeah. And all of a sudden, you go through a leaf gauge, and you're basically trying to figure out where their first point of contact is. Where is the place where they touch? Are they touching everything the same in centric relation, centric occlusion, or is there something in the way?
Right.
And all of a sudden, you start bringing this into focus, and you say, and you've got like 2 to 3 millimeters sometimes of leaves in there between their teeth. So their anterior is open 2 to 3 millimeters, and you start asking if they hit something, and they're like, "Yeah, I'm hitting right back here," and you're like, "Whoa!" And so you're like, "Let me just tell you what's going on, Miss Jones. I want you to see the thickness of this little gauge. Your front teeth are open this much, and your back teeth are touching.
Yep.
So what I need you to understand is, you are hitting in the back way before you're hitting in the front when your jaw is in its fully relaxed position. So is it any wonder that you are missing second molars on one side, and on the other side you've just fractured in half, number 15, and that's the place that you hit first when I put you into leaf gauge, and that's the place where I see a lot of wear on 18, distobuccal cusp, or whatever it is. And all of a sudden, like you say, you start to make sense of it. Your patient makes sense of it. Your assistant makes sense of it. And now things start to come into focus about how you determine what's going on with these patients. So it just really,
it's amazing.
It just really made such a difference that we're not saying necessarily just go buy a leaf gauge, because
dude, you
can go to Great Lakes Ortho and you can buy a leaf gauge. I mean, great, but just buying it. I bought one too. I bought one too. And it was like, I'm looking at it like, yeah, man, this is cool. I got a leaf gauge now. But until you actually learn how to use it, and Spear Online has got some great videos on this. Yeah. Even if you don't want to go to the course, at least you can get a really good idea from what's going on online. And then practice it on your team, and you'll be amazed at how many people have this problem. So we could spend a lot longer on that. But
there's so many ways to say use this thing.
It's a product of the week for sure.
Product of the week is leaf gauge. Many of them out there, Great Lakes is probably the go-to place for the leaf gauge, and the one that we're using. So, John, what about these patients that you've done everything right?
Yeah.
Everything right. For instance, you've actually put them into the most skeletal position. You've given them the proper guard. And they're just not getting better. Like, they're really not getting better. In fact, in some ways, you've made them worse.
Oh man. And this is where we take all that stuff we just told you,
and you just throw it in the trash.
And you have to,
Because let me just tell you right now, this is the true practice changer. And when we come back from this, we're going to show you a picture of what is going to change your practice. So, John, one of the things that we've been utilizing in our office to evaluate problems is the cone beam machine, the Ray Scan.
Yeah.
And we have the Ray Scan Alpha. We love the 9x9 field of view. And Practice Changer last year was our CT scanner. And this year, you and I have been kind of utilizing it in a different way. And that's to look at maybe positioning that patient to where we can actually visualize the airway. And I know that the new Ray Scan Alpha Plus is a 9x13 so that you for sure get the airway every time. And in fact, the 9x9, all that you need to do is position that patient a little further forward. You might cut the incisal edge off.
Right.
Or in some larger patients, you may end up cutting the anterior maxilla off, but at least, you can still see the airway in the 9x9. But if you want to for sure get it, the 9x13 will give you that airway. And one thing that's kind of wild about looking at airways is that you see how narrow. I measured one the other day with a patient that had a Mallampati of 4, tonsillar score of 3, an adult patient, nasal septum, high palatal vault, nasal septal defect, deviation, and snores, and their airway was 1.3 millimeters.
I love it.
You're breathing through a straw, buddy, or smaller
Exactly.
than a straw. And I think
Yep.
that's one thing that we like about the CT is it has so many things that we can actually use it for. John, what's your thoughts on it?
And I think that that, of course, has changed what I do as well. And as we're talking about this segment of the show about practice changers, we think that if you're looking at treating more occlusion and dental sleep medicine, we're not saying that a CT is everything,
Right.
because it's only a part of your treatment planning and your diagnostics. But we do think that it is an indispensable tool.
Yep.
And it just so happens that we know a guy who can get you
The new
the
Alpha
CT
Plus.
machine. These are the droids you're looking for.
Yes.
And that's the Ray Scan Alpha Plus. And the Dental Crafters Network is a resource that, we've talked about how they truly go from the implant all the way to the crown, but they even go back before that. They go to the guide, yes, we knew that, but they actually even distribute, in what our opinion is one of the better CT machines out there, especially when you take into account the features and the value that you get for this machine. And you can get this from them. So how cool is that you can get support for your CT machine from the same company that's making your guides? How valuable to be able to call somebody there at the Dental Crafters Network and say, hey, can you take a look at my CT machine, because I want to make sure that I'm properly calibrated for what I need for this guide, or had an issue with the guide not fitting so well. Can you make sure my CT machine works? And they're like, yeah, let me get the guy who does that. So
Yep.
if you are looking at dental CT machines, you owe it to yourself to go to a company that not only understands CT, but understands what you're using it for and understands how to help you make a decision on which CT machine to buy.
Shout out to Dental Crafters Network this week on the Dental Guys, and thank you so much for sponsoring them. They are one of the main reasons that we bought the Ray Scan. Before they were even distributors, we contacted Implant Solutions, who has been making guides for years and years and looks at hundreds of CTs a day. And I said, Ellen, who is shooting the best CTs and what are we looking for in a CT machine? And I just had her send over. And if you go back and you look at how to choose a dental cone beam machine,
Our episode on that,
you'll see a video that I put together from Implant Solutions before they were even a sponsor. And this is how much we love them. So if you're interested in taking your dentistry to the next level and incorporating CT imaging technology, we want you to call the Dental Crafters Network and talk to them about their CT machine that they distribute, the Ray Scan. Alpha and Alpha Plus, call 1-800-472-8302. Make sure you mention the dental guys. That's 1-800-472-8302. Call today. John, it is this thing that we mentioned called sleep apnea that has confounded my mind in something like nothing ever in dentistry, because whenever these patients that you thought were going to get better from TMD treatment are not getting better now, they're in fact getting worse because you cause their jaw to go into the most relaxed, most posterior retruded position, and you just made their airway worse.
Right. You put a splint in there. You know, starting the first half of the show, we just told you about how splint design and how good splints are. But then we were challenged to explain, well, what happens when you take a patient who may have apnea, which, by the way, is a huge segment of our population.
Oh, man.
And then you put a splint, say a maxillary full arch splint in that patient's mouth. What happens to their airway? What happens to their ability to breathe? We know that it potentially decreases. Now, you might say, well, we open the vertical a little bit. Yeah, true. But you also put a giant piece of plastic in there that potentially constricts their airway. The question is not whether, we measured this or that. The question is, do you even know? Do you even know about this? And this was the thing. We get in there and we hear somebody who we really respect say, I don't make a splint for a patient until I've done a home sleep test. I will not make a splint.
I did a double take whenever Kevin Quetian said
I was
that.
like, what?
I was like, what did you just say?
And all of a sudden you start realizing that all the stuff that about occlusion, it's all true in a patient who doesn't have apnea, okay? But if a patient has apnea, everything that we just told you is pretty much gone, or it's like becomes a distant second.
Right.
Because apnea in patients can change everything, as Wes said. It can take a patient who otherwise would respond to everything you do, or otherwise would have those veneers last, or otherwise would not break teeth, and all of a sudden they're breaking everything you put in there. They're getting worse instead of better. Their muscles are sore. Their jaw joint is popping, and you're like, man, all my TMD treatment is not working, and my veneers are popping off.
They grind through splints.
Yep. They say I take my splint out at night.
Yes.
I can't wear a splint.
I can't wear a splint. Never can wear one. It gags me.
Right. And you start to realize that what's really going on in some of these patients
they can't breathe.
They can't breathe.
They can't breathe.
And the power of your brain to get you to breathe is stronger
than your teeth.
Anything we put in these people's mouth, anything they were born with.
Yep.
So all of a sudden, Wes and I are like facing this reality that's this new reality that all the stuff that we kind of thought we knew about what, and we're hearing from the same faculty somewhat that taught us about occlusion, about how important interferences were,
right?
About how important pathway wear was, and they're saying, well, guys, yes, that's important, but you'd better have an apnea discussion before you talk about all this other stuff, because if you miss that, then
you miss the
not
hallmark.
only are you not going to be successful, but the patient could die.
Yeah.
I mean.
Yeah. Yeah, it's not
heavy.
a matter of whether you want to treat sleep medicine. That's not what we're saying.
Yeah.
What we're saying is that you need to recognize that sleep apnea exists. You also need to recognize that upper airway obstructions exist without apneas. So meaning like somebody that is not apneic but snores, okay? Right. Somebody that's not apneic that snores is not sleeping well because they're laboring all night. Mm-hmm. Is that your responsibility to recognize that there's a problem? I think that we're starting to get to that point in dentistry where we need to be looking just like we're looking at the tongue for oral cancer, just like you were trained to kind of palpate for lymph nodes and maybe check for, a little bit of, was something with your thyroid here. I mean, who feels on patients' necks more than we do?
Right.
And it's not like you have to know every diagnosis for all these things. It's just that you need to recognize.
Well, we need to, I think, have everybody just be familiar enough with the most basic of things.
I don't think it's that hard either, John. I don't think it's that hard to really recognize that there is a problem.
Yeah.
Or
I think just knowing how to ask some simple questions.
Yep.
If you, what's that?
I agree.
Yeah, I mean, if you don't know what stop bang is,
right,
then you need to learn what that means, and you need to be asking patients how they're sleeping, and you need to understand when to refer. You need to understand how the process works, at least in the most basic of ways. And even if you want to look at it, some people are like, as you said, Wes, well, I don't want to treat sleep apnea. I don't want to do it. That's fine. But just be aware, your stuff's going to break, and you're not going to know why. And so I think that you owe it to yourself, even if all you're thinking about is just, I'm going to make sure that I don't want to have patients that are breaking stuff, or I don't want to have patients that are wearing my dentistry out or making my stuff look bad, or patients that won't respond to splint therapy, then you need to at least consider the fact that you might have a missing link and that you're going to have potentially problems with your dentistry. I know that I definitely have patients that I now look back on that I just thought, oh, they just grind, and that's what they do, and they just grind and they break everything. I used to call those patients chipper shredders. I would say, like, you throw everything. It's like a chipper shredder, you throw it in the top, and it's like, and like it comes out the other end just mangled. And I have patients that
3 night guards a year.
Yeah, and I would just call them that. Like, you put like night guard, you put a PFM, you finally put like full contra zirconia, and then it maybe holds, but now their tooth hurts all the time.
Right.
So they crack the tooth in half. So I used to be like, well, that's just how they are. They just destroy everything.
You get that referral from that doctor and says, hey, look, man, I've tried everything I can.
Yeah, they break everything.
Good luck.
They're chipper shredders.
They chipper
and
shredders.
So I realize now that it was my problem in most of these patients that I did not think or know enough about apnea. And now a lot of these patients that I used to call that,
right,
as we're talking, and again, it's like your team starts to see it too. Your team starts to see that these patients that, were breaking stuff all the time, you just ask them a few questions and they start answering them, and it's disturbing.
So,
because you're like, how long have they had this problem?
It's like crazy, because it seems like we live in East Tennessee, and we have a lot of disease here in East Tennessee, be it hypertension, obesity, diabetes, COPD.
Biscuit and gravy diseases.
Oh yeah, it's biscuits and gravy down here, baby. And here's the thing, is that obesity and all these things are risk factors and for apnea. And we live in a state where we see these problems, and in a grand scale, and maybe you don't see them as much as we do, but 1/3 of all patients have apnea. And I feel like, John, the incidence level in East Tennessee is maybe a little higher than that. I would say maybe pushing 40%, because of the amount of syndrome X, as we call it, which is all those diseases that we just mentioned. And people are sick.
So talk about this patient.
Yeah. Okay. So let me put
you
this
saw
picture
the
up.
other day.
Okay. So
it really brings it home. This is how we got to finish it out.
We're going to finish the whole show right here. If you're on your lawnmower, as we've said, in the car, you need to stop and you need to go to the YouTube and fast forward to this part of the podcast and pull up this image, because what you're looking at here, John, is you're looking at an image of a patient that comes in on an emergency, my typical 10 to 20 minute emergency. The assistant comes in and tells me, hey, Joe or Jim or whatever her name is, she broke a tooth and it's rough to her tongue. And so I go in there and I sit down and I look in the mouth, and I typically, as I do and as John does, we use our DSLR and we take a quick picture so that we can actually physically show it on an iPad or the screen, so that we're not sitting there pointing to the case in the mouth. That's a little pearl for you. If you'd have an intraoral camera or some type of extraoral camera, take a picture. Because what you're seeing here is tooth number 14 and tooth number, let's call it 13. The marginal ridge is fractured off the mesial of 14. It's a full contour, it's an old lava crown, ceramic baked over a zirconium coping. Number 13 was done at the same time. Same thing, ceramic baked over zirconium coping, and the lingual cusp is chipped on number 13. Okay? Well, we all know how to be fixers. Well, we could polish 13 and do a new crown on 14. And that's acceptable treatment. You could actually redo both crowns, but I don't think that's necessary. But let's redo 14. But did I even talk about that with this patient? No, because this patient, I began to ask questions. One, I'm like, how have you been feeling lately? And she's like, I just been feeling terrible. And to be honest with you, she said, I think I'm clenching my teeth at night. She's like, I used to do that. I said, did you ever wear a splint? She said, oh yeah. She's like, I've wore splints before. And she's like, I haven't wore one for a very long time. I said, well, has it been stressful lately? She's like, oh yeah, it's been stressful. And she's like, just a lot of stuff going on. And she's like, I feel like I'm waking up and my jaws are sore. I'm actually waking up at night. Okay. Key point, clenching my teeth. And I said, well, I started doing some examination, and she was a patient of record. So I pull up the images that I took 1.5 years ago of the same quadrant.
Yep.
It's not fractured. Okay. And I show her that, and she's like, man,
so you know when it happened.
So we know exactly when it happened, and it happened recently. And she says, well, I went ahead and polished it so that her tongue would feel better. Obviously, you can't polish 14 mesial. So long story short, you start going through this patient's history. Notice there's premolar missing here in this picture. She had serial extraction. She's 58 years old. She has a retrognathic mandible. She has a small maxilla. Her teeth are, if you look at her occlusion, she has a situation where she's retroclined because they had to collapse and close all the spaces from the 4-by extraction, the serial extraction. She has tori, high palatal vault. She has a nasal septal defect that she's already had repaired once. She had palatal expansion when she was younger, and she has a Mallampati score of 4. You can't hardly retract her tongue to see her tonsils. Her uvula is elongated, and she has hypertension. And then I asked her one question as I was looking at all this. I said, do you snore? And she's like, oh, yeah, I snore. And I'm like, you have hypertension too, don't you? And she said, yeah, I do. She's like, I have blood pressure problems. I said, ma'am, I think that you may have obstructive sleep apnea, and that's why you may be clenching and breaking your teeth here. I said, let's talk about this. She says, I already know you're right. She's like,
I already know you're right.
She's like, I know you're right, because I've been waking up and I've been feeling out of breath, especially lately. So now we just went from repairing. Okay, so we could actually repair this and give the lady a splint and just go on about our way, and we just made the patient worse.
That's right. Potentially, this is a patient who
this
will
is
say,
why it's a practice
I could
changer,
never
John.
wear a splint. I couldn't wear that splint, and you go, oh, man, well, what do I do now? Because the patient's breaking stuff and they can't wear a splint, and you just kind of stop there.
But see, here's
where
the
else
thing
can
is,
you even go?
we blame the lab in this case. Now, this crown's been on for 15 years, and we say, well, that's just wearing out. No, it's not. It's not because they baked the ceramic wrong, because, to be honest with you, Emax, John, is a lot weaker substance, and we know we can put Emax on second molars with a 1 to 1.5 millimeter reduction, and it shouldn't break.
Sure.
And so what are we saying here? We're saying that our practice has changed.
Yep.
And that
I think
now
that we look at these cases now, and it's not that, again, that patients don't just grind their teeth. So don't get us wrong here. Lots of patients just grind their teeth. we've looked at the literature.
And we're not
There's
saying everybody
definitely-
grinds their teeth is everybody that's got
has apnea.
No,
no,
it's a
'cause
risk
the research
factor.
does not support it. But there are some people
It's a predictor.
there are some people that's what's going on, and that's what's causing a lot of their tooth problems. And whether you want to look at it from a tooth perspective of trying to prevent what Wes just showed you with a broken crown or broken veneers or broken teeth, or whether you want to look at it from, I actually want to get people better, and I want to, because we haven't even talked about appliances, and we're not going to, because the point is not to go into this like treatment and how are we treating patients. That's something you need to go take courses on. We're not going to teach you sleep apnea, but we want to say that, if you can look at it just to help your dentistry, or you can look at it as, I'm actually going to try to take patients that have failed CPAP and I'm going to try to make appliances, make them better. Or I'm just going to try to diagnose patients, even like not diagnose, but I'm going to try to help patients gain a diagnosis so that I can then treat them, or a sleep medicine doctor can treat them, or we can work together.
Yep.
You can take it as far as you want.
Yeah, you can.
But the time has passed for dentists to say, well, it's a medical problem.
Right.
Because it's not just a medical problem, and we see these patients a lot, and we have a responsibility to understand it. Again, it comes back to what we say many times is, we're doctors. We are experts in this part of the body, and we see patients more than the average doctor, MD, does because of the way the relationships we build with our patients.
Mm-hmm.
So this last year has seen Wes and I go from, not really knowing a lot about why we were doing, what was working, what wasn't with our bites and occlusion, understanding that more, and then having that whole thing kind of blown up from the inside out again, with needing to understand that all the rules go out the window with these sleep patients.
That's right.
And that you need to have a completely different set of rules in your practice of how you filter these patients through to who needs sleep treatment, who doesn't, who needs occlusal therapy, who doesn't, who can we safely treat with full mouth dentistry versus who needs an apnea consult versus who needs a splint versus who needs for us to stop and stop just seeing patients every 6 months for hygiene when we see things that are continuing to go wrong, and do a new comprehensive exam as if the patient's seen brand new, because we're seeing things that we now understand we didn't. It's like, I'm seeing that, Wes, like patients that I've seen for a long time where I'm having to stop and going, you know what? I understand more now than I did. I say this like almost every day, and it's like hard for me because I don't want to admit that I didn't know stuff, because it's like that's how we're wired.
Right.
But I said to somebody just today, I said, about 3 or 4 years ago, I wouldn't have even been saying a lot of these things to you because I didn't understand them as well as I do now. But I need a 30-minute appointment with you, because there's things that are going on in your mouth that I think may be related to your overall health.
Like, what patient has ever
important.
rejected that?
Patients, yeah. They don't say no.
They never say no to say, hey, could you come back and let me really spend about 30 minutes with you?
Yep.
And they're like, sure, no problem, doc. What do you think is going on? I said, you know what? I don't know yet, but I'd like to spend a lot of time just dedicated just to you and some issues I'm seeing.
Yeah, because I understand things that I didn't understand.
Because there's some things I didn't know years ago, and now I know them, and I'd like to help you if I can. And that's today's, practice changer this year's practice changer in my book is the combination of TMD treatment, and they're recognizing that there is sleep breathing disorders, and that they go hand in hand. For years, John, we wanted people to believe that periodontal disease was linked to overall health, and it took the Surgeon General's report to really come out and say, yes, there is a link, there is a problem, and there is research. And now the dentists are on the receiving end of, hey, there's medical evidence that sleep is causing tooth and TMD issues. Mm-hmm. And now you guys need to recognize that, and now you're on the receiving end. So the question is, are you going to step up?
Yeah, what are you going to do about it?
What are you going to do about it? Like, it really is a great thing to start looking at, because at the ADA this year, there's 2 great speakers. Now, the ADA is done past by the time this is released, but you need to seek out some of these major meetings where you can go and at least listen to an hour or two by some of the top sleep doctors in the United States that are treating sleep from a dental perspective. And we've been privy to some of those conversations, some of those discussions, and it's life-changing as far as a practice. It's practice-changing.
Yeah.
And so I'm excited about it, John.
Absolutely.
I'm excited about it. So if you're listening to this episode and you're thinking, man, I need to find out more about that, well, listen, hey, send us a tweet, leave us a message on Facebook and say, hey, Wes and John, where can I go to learn more about temporomandibular disorder, problems with sleep? And if you want to know more about the leaf gauge, send us a shout out on Facebook or even YouTube. We have some people that are always watching us on YouTube. The following is getting larger there. Yep. And I was excited about our live Facebook thing. We'll continue to try to do some of that as time permits.
Yeah, that was cool.
That was really cool. It was really cool. And if you're listening to this on iTunes, go ahead and go right over there and give us a 5-star rating. That really helps us. It helps move us up the rankings so that other dentists can find us. And we want people to know about the dental guys, because the more people that know about the dental guys, the larger our community goes, and the more clinical things that we can bring to the table to help you guys take your practice to the next level, and to help us to continue to be able to help you and us to learn, the great things about what research is showing us and what empirical evidence we're finding is proving out our research. And so for Wes and John, we are the Dental Guys.